Welcome to our PowerPoint module. This week we're going to talk about sexuality, sexual behavior, and health. And by sexuality, I mean sexual identity. So really, sexual identity and sexual behavior are two very different topics, right? But I do hope to address both of these in class, in this PowerPoint module and during our class session this week, okay? I do hope to address a couple of specific topics and examples in class, and all of this is going to be done within the lens of the social determinants of health, as usual. Our objectives for this week, well, there's one main objective, and that is to discuss sexual behavior and sexual identity as social determinants of health. I'm also going to introduce this topic by defining sexual health, what it is, why it's important, and really what are the implications for interventions related to sexual health, whether that's sexual behavior or behaviors connected to sexual identity. I expect this will take about an hour. There are a number of slides, but I think going through the slides, for the most part, the slides themselves are pretty brief. Here are our deliverables for this week. As usual, you have your reading question due Monday night. You have your PowerPoint module due Tuesday night. And this week we do have our second exam. So exam 2 is going to be posted by Tuesday evening, and you'll have until this Friday at 11:59 p.m. to turn it in. Okay, so this is what we have coming up this week. Here's your opening question, and we're going to start this module by talking about sexual behavior, and then we'll get into sexuality, sexual identity, and such. So here's your opening question. In what ways is sexual behavior a social determinant of health? In your response, consider at least one distal determinant of sexual behavior, so something distally that is shaping sexual behavior, and one health outcome that is shaped by sexual behavior. And to clarify that, I am framing sexual behavior here as more of a proximal determinant of health, right? It is more closely and directly related to health outcomes. And there are a number of distal determinants that do shape individual sexual behavior. Okay, so I want you to consider those distal determinants and then also consider a health outcome that is shaped by sexual behavior. And there are many. There are many ways you could answer this question. All right, so you can pause here, respond to that opening question, and then come back for the rest of the module. So as I mentioned a few slides ago, I want to start this conversation about sexual behavior and sexuality in connection to the social determinants of health by defining sexual health, because that is fundamentally what we're talking about here. The positive outcome that we want to have in our population is good sexual health. So what do we mean by that? This is a definition from the World Health Organization, and according to the WHO, sexual health is not just about the absence of disease or the absence of a sexually transmitted infection. Sexual health is much broader than that. It's about well-being across physical, emotional, mental, and social domains. In order to have good sexual health, and we can think about this at the population level, in order to have a population with good sexual health, we need to consider our environment. We need to consider the exposure to or risk of discrimination and violence, coercion as perhaps a part of our culture in connection to sexuality. These are all threats to having good sexual health in a population. So really, good sexual health at the population level is very interconnected to the rights and the freedoms of individuals to enjoy sexuality in a safe way. I do really appreciate this broader definition because I think that within the field of public health, when we think about sexual health, we're usually thinking about STIs or unwanted pregnancy. And these are very important. They are very important. But we can also think about this in a somewhat more positive light, that sexual health is about empowerment, it's about well-being, and it's a big part of our lives. So I do appreciate this definition. And I don't know if you noticed in the image on the left side here, the three little cartoon figures there. One looks like a condom, the one on the other side is an IUD, and then the one in the middle is a pill, and that's PrEP. And PrEP is a medication that is used to prevent, it's very effective in preventing contracting HIV, even when having intercourse with someone who is HIV positive. So just to give you a bit of a glimpse into what those cartoons are. Anyway, we'll move on, but sexual health, this is a very important definition for us. Now we went over the definition of sexual health. Now I want to talk about the number of barriers that exist to good sexual health. And this is one area really where the social determinants of health come in. And we will continue to discuss a number of these, both in the module and in class. So what are some barriers to sexual health that we see in the US? And we see this across contexts as well, but I am going to be a little more US specific in talking about this. The first barrier that I have listed here is one that we are going to spend some time on, and that is inadequate sex education. On the right of the screen, you see a figure from the Guttmacher Institute, and this is showing you whether or not there is a policy by state that requires covering contraception in STI and HIV education in public school systems. And what you see here is that a number of states, the ones that are in the darker bluish green, do not require that contraception be covered in sex ed programs in public schools. And this is a problem, right? A number of states do not require this. And we see huge variation in the US in the quality and the content of sex education programs, which we will spend more time on. Other barriers include lack of access to contraceptives and lack of access to, even more broadly, reproductive and family planning services. There's also substantial state-level variation in access to reproductive and family planning services. And the policies at the state level attempting to really block access to these kinds of services there's been a lot of variation by state, and there has been increase in legislation that's really meant to block access to reproductive and family planning services for women. So this is another barrier. I have a couple of cultural barriers here as well. So normalization of sexual violence against women, and this is very tied into toxic masculinity that we have talked about to an extent in class, I believe, but the normalization of sexual violence against women certainly is a health risk for women, and it is a barrier to sexual health for women. Toxic masculinity we can consider to be a barrier to sexual health for everybody, of all genders. And then the last one that I have here is stigma, labeling, and discrimination against LGBT people, and we will spend time on this at the end of the PowerPoint module, and I do hope to discuss this more in class as well. This is not a full list, but I did want to give you a sense of some of the barriers in resources, environmental barriers, but also cultural barriers, and the ways in which our cultural ideals or issues within our culture really do connect intricately and intimately to sexual health. So now I have a video for you to watch, and this is another clip. I know we've used at least one of these before in this class, but this is another clip from last week tonight with John Oliver. This topic is sex education, and it's all about sex education in the US and really the lack of policy and regulation around sex education in public schools in the US. I want you to answer this pretty open-ended video question after you watch the video. So the question is, what is the current state of sex education in US public schools? Consider the ways in which the quality of sex ed in schools affects population health. You could probably answer this without watching the video, but it is a very, I think, well done video clip by John Oliver. I will warn you, there is discussion of sexual assault in this video, and there is discussion of sexual assault coming from a sexual assault survivor. Okay, so I do want to at least make you aware of that before you go in and watch this. It is not that it is all that explicit, but it still is a sensitive topic. Okay, so please do pause, watch the video, and answer this video question on Inquire. I want to spend the remainder of the module for this week talking about LGBTQ health. And we know, based on a wide array of research, that LGBTQ people, and in particular LGBTQ youth, experience poor mental health, and that will be our primary focus in the remainder of this module. But we could also talk about physical health disparities. We could talk about risk of STIs and increased risk of STIs, especially among men who have sex with men. We could also talk about barriers in accessing important healthcare services and resources. These are all important areas of health disparities research within the LGBTQ population. There is a lot we could talk about here, and I do, as usual, wish that we had more time to talk about all of these things. But we're going to focus on mental health among LGB youth and young adults. We will have time in class to perhaps cover more topics as well based on your interest. This is coming from the US Department of Health and Human Services. They do, I believe it's annual, it might be biannual, they do a survey called the National Survey on Drug Use and Health. Interestingly, within the survey, they also look at mental health and mental illness. So here we see the rates of serious mental illness among LGB young adults, and then middle adults and older adults. The green line is looking at those ages 50 plus, and we see that overall rates of serious mental illness are lower. There has been some change over time with an increase around 2016 and then a decline after that. If we look at ages 26 to 49, that is the dark blue line, we do see an increase over time. Interestingly, it looks like a mirror image of the older adults. But we do see an increase to nearly 20% by 2018. And then among the younger age group, ages 18 to 25, we see the highest rates of serious mental illness, all the way up to, looks like 22% about, or 21.8% right there. This is alarming. I mean, those are very high percentages for this demographic. And we have seen an increase over time. So this is definitely something to look at. And this is a pattern that we see if you were to compare this to those who are not LGB, we would definitely see a pretty significant disparity. This figure, coming from the same data source, is looking at major depressive episodes among, I should say, lesbian, gay, bisexual adults. That's what LGB stands for. And we're not including trans adults in here because trans people, I mean, this is a fundamentally different population and actually a more marginalized population. So we are not looking at trans adults because we would see some major differences if we looked at the LGB population and the trans population and compared those populations. But we are focusing on LGB adults here. And what you see, let's see, for 18 to 25, that's the age group that we have on the far left. There was an increase in major depressive episodes by a year, and it looks like it seemed to like taper off by 2018 a bit. We're only looking at 4 years here, so you know, it's not too much of a trend, but we do see a pretty sharp increase from 2015 to 2018. We don't see the same increase or the same levels of major depressive episodes for those who are 26 to 49 or 50 or older. But it is important to point out that across all of these groups, those who are LGB adults experience much higher or much more in terms of major depressive episodes compared to the overall US population within those same age groups. So for example, for ages 18 to 25, LGB adults have a major depressive episode rate of 31.2%. So 31.2% of LGB adults ages 18 to 25 have had at least one major depressive episode. If we look at the overall US population, ages 18 to 25, that number is 13.8%. So that's more than double. And we see a similar pattern when we're looking at ages 26 to 49, and when we're looking at ages 50 and older. And the last figure I'm going to show you on this topic is looking at suicide, so suicidal thoughts, plans, and attempts among LGBT adults. And we see that for LGBT adults in 2018, oh, that's interesting. So in 2008, they didn't have any data available. I don't know why they included it on the graph, but in 2018, they found that 26.6% of LGBT adults had reported having serious thoughts about suicide. And this is looking at ages 18 to 25. So it's in that young adult range. Compared to the overall US population, where we have 11%. So 11% of people in the overall population in this age group had serious thoughts of suicide. Huge difference. And then we see that for making a plan and attempting suicide, there is a similar pattern. For example, if we look at LGBT adults who have attempted suicide, it is 5.4% of LGBT adults. In the overall US population, in this age group, 18 to 25, 1.9% of adults overall have attempted suicide. So there is a major difference, more than twice the rate of suicide attempts in LGBT adults. Clearly, there is something at play, an inequity at play that leads to such wide disparities in mental health. So that's what we'll talk about in the next couple of slides. So the last few slides showed you some pretty disturbing and stark statistics about really the poor mental health experienced by LGBT adults in the US. Now the question becomes why? Why do we see this disparity, and why do we see such poor mental health among LGBT adults in the US? And in order to answer that question, or at least begin to answer that question, we need to consider the social determinants of LGBTQ health, right? And we can think about this in terms of mental health, but we can also think about LGBTQ health in terms of physical health. Here we're focusing more on mental health. So this is a figure that I pulled from a book that does focus on LGBTQ health disparities and the social determinants of LGBTQ health. There are a number of social factors across institutions, across domains, that we can consider in order to better understand why we see such health disparities in mental health and in physical health. I won't go through every single one of these, but I do want to highlight a few. The first is lack of data. Up until recently, there was very little research, very little data available in order to research LGBTQ populations. There is a lack of data, and this is in part because in collecting national samples, where a lot of public health and epidemiology research comes from, there is not really much of a concerted effort, or at least has not been until recently, to make sure that there is adequate representation of the LGBTQ population or populations within the data collection process. So there is a lack of data. This is beginning to change, fortunately. We also see, thinking about economic conditions, and here we have poverty listed as one of the social determinants of LGBTQ health. There are significant gaps in income and wealth. If we look at those who are not LGBTQ and compare them to those who are. There are a number of reasons for this. It could be overt workplace discrimination, employment discrimination, which there are not states vary significantly on the protections that they provide LGBTQ people when applying for a job in terms of employment protections and anti-discrimination law. Some states do not have any anti-discrimination law in employment or in housing. So housing is also an important one here. One that was covered in one of your readings for this week was stress and coping, and the stress of being stigmatized, discriminated against, excluded. All of these are really important contributors to mental health and mental illness, right? we could talk about all of these in greater detail, and I do hope that we get to plan to talk, or that we do get to talk about some of these in class this week. But what I want you to know is that there are a number of social factors that we could consider as determinants of health for LGBTQ people in the US. Here's a content question to expand on the issue of mental health disparities and LGBTQ youth specifically. And this is a very current and recent news clip. I call it a content question, but I guess it's actually a audio question where I'm asking you to listen to a news clip. There is a recording. You can also just read the article if you'd like, and then answer this content question on Inquire. How has the mental health of LGBTQ youth been affected by the COVID-19 pandemic? There are a number of ways to answer this question and a number of reasons that are provided to you in this article. So listen to the news clip or read the news clip from NPR. The link is on Inquire, and then answer this question, and then return to the module for the last few slides. I want to end this PowerPoint module by briefly discussing one of the readings that you did for this week. So this is the Herrick and colleagues reading that was looking at internalized homophobia and resilience or resolution of that homophobia and how this is related to positive health outcomes. I assigned this reading in part because we know that mental and physical health is a very important part of providing equity for LGBTQ people, right? Being able to address the disparities that we see in physical and mental health. I also assigned this reading because I think it does give a little bit of hope, a sort of hope, by showing that being able to overcome internalized homophobia is connected to more positive health outcomes. Now, this is the scale that they used, called the internalized homophobia scale, of 9 items, and I will let you read those on your own. What they did, just to refresh your memory, is they asked a number of, they're simple as men who have sex with men, and they asked them, when you first came out, how would you assess yourself or your mental well-being based on these statements? And then they asked them, okay, well, how about in the past year? How would you respond to these questions? And then they looked at change over time, and those who have resolved that internalized homophobia, in other words, their responses changed for the better on these items, they looked at whether they showed different or better health outcomes compared to those who continue to have internalized homophobia. So maybe they didn't change their responses all that much. These are the items that they used, and you can see from time number 1 to time 2, overall, if we're just looking at averages, there's a pretty substantial change, a pretty substantial decrease in agreement to these statements across time, which is a positive trend, right? This is something that you would want to see, the reduction in internalized homophobia. So now the question becomes, how is this related to health? So this is what they found, and this is presenting odds ratios for a number of outcomes that, I mean, it is kind of a double negative here. Not engaging in negative outcomes is really what they're looking at. So no or low stimulant use, no or low distress, no low stress, and so on. So they're looking at whether these negative outcomes are present or absent depending on internalized homophobia resolution. So among those who have resolved that internalized homophobia that they once had, do they have more positive health outcomes, meaning that they are not engaging in these negative outcomes or these negative behaviors. And so what they find almost across the board is that resolving internalized homophobia is associated with higher odds of, for example, not being in distress, or higher odds of not experiencing stress, so having no or low stress. And we can tell this by looking at the odds ratio. And I know we talked about this in class at some point, but in a nutshell, when you're looking at an odds ratio, if it's greater than 1, that means we have a positive association where among our one group we have higher levels compared to the other group. And then if it's below 1, that means we have more of a negative association. I'm not going to get into it in any greater detail than that, but this really does show what we would expect, that there are better health outcomes among those who have resolved that internalized homophobia compared to those who have not. So this does give a bit of hope. That's why I assigned it. I would also like to say one of the big caveats here is we're relying on individual resilience here to be able to manage and essentially resolve this feeling of internalized homophobia that is very much rooted in our social institutions and our social systems, right? So the better solution here, instead of having, encouraging people to get over the internalized homophobia that they have lived with for a chunk of their lives, is to change the way our society, our culture, our social structures operate so that homophobia isn't there in the first place. But that is an aside. We can talk more about that in class. But it is encouraging to see that resolving of that homophobia is associated with better health. All right, that concludes our PowerPoint module for this week. As usual, we're going to have our in-class group meet on Wednesday of this week, and we're going to have our Zoom group meet on Friday. In class, we're going to talk about these topics further and also talk about interventions to improve sexual health among youth in the US in particular. Please do come prepared to discuss. I'll see you in class.